Hey, it's Dr. Tony Hampton here, and today I may ruffle a few white coats, but I'll do it in love. A patient told her rheumatology specialist that her rheumatoid arthritis pain had vanished after cutting out sugar. The reply? That's not the reason. I wish I was making this up. Then the same patient reversed her type 2 diabetes and brought her A1C down to 5.1 with diet, and another doctor was stunned. So here's the question. If food can calm inflammation and stabilize blood sugar, why is nutrition still treated like a footnote by doctors? And if that's a question you've been asking yourself, you've clicked on the right video. And to help bring it home, we'll focus on rheumatoid arthritis. We're covering what rheumatoid arthritis is, what remission really means, the evidence for anti-inflammatory and low-carb or keto approaches, why doctors hesitate to stop meds, how to talk to your clinician, and the exact data to track so you can make a safe case for tapering. And stick around to the end for a respectful but spicy checklist you can take to your next office visit. So what is rheumatoid arthritis? RA is an immune-mediated arthritis that inflames joints and when uncontrolled damages them. Our modern target isn't less pain, it's remission or at least low disease activity with a treat-to-target strategy. The American College of Rheumatology says that after you've sustained remission for about 6 months, you can consider tapering disease-modifying therapy, but not abruptly stopping everything. So what counts as remission? Definitions use composite scores: swollen joint count, tender joint count, patient global assessment, and CRP. Boolean, which is a way to measure remission, is a specific, strict definition of remission used in the treatment of rheumatoid arthritis. Boolean remission means each is less than or equal to 1. Or you can use index cutoffs like SDAI less than 3.3 or CDAI less than 2.8. In plain English, almost no swollen or tender joints, you feel close to normal, and labs are quiet. One more lab reality check. Rheumatoid factor and anti-CCP help diagnose RA, but they usually stay positive even in remission. They're not good for tracking disease activity, so don't panic if you don't turn negative. Instead, use CRP, ESR, and a composite score instead. Now food, the root cause lever. Ketone bodies like beta-hydroxybutyrate, which rise when you cut carbs and enter ketosis, directly inhibit the NLRP3 inflammasome. That's one of the immune alarm systems that drive inflammation. That's why low-carb and keto patterns may calm inflamed joints, and why my patient and I think she has such remarkable results using these dietary patterns. We've got several RCTs of Mediterranean-style eating showing meaningful improvements in RA. Lower disease activity, improved function, less stiffness. The ADIRA trial in Sweden found better DAS28 CRP and patient-reported outcomes with an anti-inflammatory Mediterranean-like diet versus control diet. And in a classic Lancet trial, a short fasting phase followed by a plant-based diet lowered RA activity for months. That's why, although I'm a carnivore, I don't throw shade on others who get results with other dietary patterns that reduce inflammation. That's why I meet people where they are, but admit plants are not my thing. And as successful as my patients have been on low-carb, keto, and carnivore, I was surprised that there had not been a lot of research on these dietary patterns for rheumatoid arthritis. So yes, RA-specific keto RCTs are limited, but indirect evidence matters. In diabetes and prediabetes, low-carb consistently lowers hemoglobin A1C, weight, and inflammation markers, often leading to higher remission rates at 6 to 12 months, as was experienced by my patient. As the metabolic fire cools, inflammatory signaling often follows. And in the Nurses' Health Study, sugar-sweetened soda increased the risk of seropositive RA in women. Another reason to dish sugar. So no, not every specialist is wrong. They're trained to avoid flares and irreversible damage. But therapy should include lifestyle. So as a patient, if you show reliable data, many will partner with you on a taper. So let's talk meds. Why won't doctors take you off, even after you heal? In RA, we use conventional synthetic disease-modifying anti-rheumatic drugs, also known as DMARDs, like methotrexate, biologics like TNF and IL-6 blockers, and targeted synthetic DMARDs like JAK inhibitors. Methotrexate is the anchor, effective and generally safe at low doses with folic acid. but it carries risks like liver toxicity and bone marrow suppression. So we check labs and counsel carefully. TNF inhibitors require screening for latent TB and infection monitoring. JAK inhibitors carry FDA box warnings for heart events, cancer, blood clots, and death. Those are real risks weighted against undertreating a destructive disease. So why the reluctance to stop therapy cold turkey? Because flares are common when you pull meds too fast, and joint damage can accrue silently. That's why guidelines prefer dose reduction over abrupt discontinuation and advise against stopping all DMARDs at once. Here's my playbook. Track DAS28-CRP, SDAI, or CDAI. Aim for a Boolean remission if possible. Use labs that move CRP and ESR. Skip chasing RF and anti-CCP. Consider ultrasound to prove no silent synovitis. Document function with a diary or HAQ-DI. And if you've also reversed diabetes, bring that A1C and MET reduction as part of your case. On diet, start with a 4 to 6 week low-carb reset. Cut sugar, soda, starches, and ultra-processed foods. Build your plate with non-starchy vegetables, fish, eggs, meat, dairy if tolerated, olives, avocado, and olive oil. Most land between 20 to 50 total carbs a day, unless you're a carnivore like me and you just get rid of the veggies altogether. And if you were impressed with the Mediterranean data, layer in Mediterranean elements proven in trials. Extra virgin olive oil, oily fish, herbs, nuts, leafy greens. The only caveat is that I would still avoid a lot of grains and make it kind of a low-carb Mediterranean version. Here are some optional tools. Time-restricted eating, or a medically supervised fast, which some of the RA trials use to good effect. Emerging RA-specific data includes trials on ketogenic interventions with MCTs and a registered 6-week ketogenic diet RA study. The science is young, but promising, especially in lieu of what I've seen in my clinical practice. Negotiate taper carefully. After 6 months of remission, consider dose reduction of one drug at a time with close follow-up. Agree on a flare plan in advance. And remember, dose reduction is safer than sudden discontinuation. And if your doctor still refuses despite all your data, it's not that they're mean or just can't hear you, it's just their philosophy. At that point, it may be time for a respectful second opinion. At the end of the day, I just want you to know that diet can lower RA activity and even put some in remission. Sugar is not neutral. It can worsen inflammation and RA risk. And if you remove that sugar, you will earn your right to taper off medicines using data. I really hope this video restores your hope for those who needed to hear this. And if it did, hit like, subscribe, and tell me below. What changed when you changed your plate? Share this with a clinician who loves data. And my final word, with a wink. This is education, not personal medical advice. Don't ghost your meds. Earn your taper with data and a plan with your clinician. I'll see you in the next video.